The broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Linda McCauley, the nurse consultant at the Reproductive Health Program. And in the room with me today is Allison Babbitt. She's a provider liaison. She's going to keep track of the questions that you have. So we have everybody muted right now. And so if you have a question, you can do two things. You can either raise your hand and we can unmute you, or you can type into your question into the chat box. And we will then look at we will answer the questions as soon as we can. So can somebody raise their hand just to make sure that you are able to hear me? Yes. Thank you so much, because we've had technical difficulties in our webinars, but hopefully today is going to go really well. All right, so let's get started. So we're going to talk about the Reproductive Health Program scope of services. Sorry. Allison's a little busy with her finger here. So the outline of what we're going to go over is we're going to talk about the program structure. We're also going to discuss how becoming a reproductive health program, what it means and what you have to do. Looking at the program requirements. We're going to also talk a lot about the funding streams and how does that work, because that's basically the changes that you're going to be seeing. Also talk about the actual services that will be provided under our RH program. We're going to give you some scenarios, visit scenarios. Hopefully that will help with any of your questions. And then we have a couple opportunities where we stop and give you the chance to ask questions as we go forward. All right. So our reproductive health structure, basically our reproductive health program is remaining the same as far as we're still following national standards of care and the program requirements. And it's basically following what most of you who have our Title X agencies already know. This is exactly what we're doing. We just now have the additional added thing that we now have money that we can provide fee-for-service reimbursements for your visits, which is a little different from the Title X grants that you had in the past. So you will get your grant for now until probably, if we get our extension, till the end of August. But we're also going to be doing the fee-for-service reimbursement for the scope of services and visits that are enrolled into our program. So what does it mean to be an RH provider? You are needing to adhere to all the requirements for all clients that seek reproductive health services. So that means anybody that walks in your door that is seeking family planning, you will see them no matter if they qualify for the funding part of our program or not. Also, you will receive fee-for-service reimbursements for all the RH program enrolled clients. So there's two different things. Providers are enrolling into the program to be a provider. Clients are enrolling to be able to get you to be able to reimburse them on a fee for service. There's two components to our program now. So the clinical requirements, again, as we talked before, is basically the same ones that you've been doing all along. You have clinical protocols that you must follow. You have core services that you must provide. And you should be able to, you must actually refer people to resources of those medical services or social services that you are unable to provide within your clinic. We also have our fiscal requirements. We still need you to do the sliding fee scale. So all clients that come in the door will still be assessed on a sliding fee scale. And that would indicate that clients above 250 FPL will be charged for full fee because our program does not reimburse for those clients. No client shall be denied services or subjected to any variation of services because of their inability to pay. And those are the same things that we've had for 40-some years. So let's look at the different funding streams. This is the change. So Title X, for client eligibility, you still have to have some reproductive capacity. There is no residency or citizenship requirements, and there is a sliding fee scale that goes up to 250 FPL. And this program covers comprehensive family planning and related preventative health services. C-Care is also reproductive capacity. You must reside in Oregon or have an Oregon address. You have to be a U.S. citizen or an eligible immigrant, and you must be below the 250 of FPL. This still remains, it has to be a contraceptive management service related to the prevention of pregnancy. RHEA, which is the new law that was passed last summer, is a little different in that it basically is people have to be able to become pregnant, which really puts it down to women. They must be able to, we must reside in Oregon. They are neither a U.S. citizen or an eligible immigrant, and that too, they are below 250% of the FPL. But this one also gives you a more broad scope of preventive reproductive health services without the context of being related to family planning. So when we go behind the scenes from our perspective, we're going to kind of give you an update of how this is going to work. So most people, regardless of their citizenship, their immigration status, their sex, will qualify for free services for a broad range of reproductive health services through our program. We try to streamline that so that instead of having multiple different enrollment forms, we have one and a client would complete that. And then we'll reimburse for covered services based on the information that you have gathered or collected from the enrollment form, which includes their citizenship or immigration status and the sex assigned at birth. Also, we will look at the information that's provided from the client visit record, which would then give us the type of service and the diagnosis codes. So when we look at the whole program, the whole work of reproductive health services in Oregon, there are multiple programs that breed together as a patchwork to make a big coverage for services in Oregon. We have our RH program, we have the Oregon Health Plan, we have Cowan and Cowan Plus, and then there's also private insurance. So hopefully with all of those different funding sources, we're going to have the ability to make it more sustainable in your agency. Questions?
We had one question. It was my understanding that C-Care includes visitors to Oregon.
So the one question is, it is my understanding that C-Care includes visitors to Oregon. So C-Care does not, but the RH program, which, well, we've braided into the Title 10, which is maybe there's no residency, there's no duration of that, there's no citizenship. That is where that reimbursement will come out of that funding. Next question is, where can we find the enrollment form? We have posted it online in the client enrollment page for healthoregon.org/RH client enrollment.
And it's posted in English, Russian, and Korean right now.
And we do have it in English, Spanish, English, Russian, and Korean.
And it will be posted in simplified and
we will have other languages posted as we get them translated. So question is, does RHEA only apply to women? The previous slide so that you can get services regardless of your sex. So remember, our RH program is braiding different funding sources together, and the RH program will be reimbursing. That will happen on our end when we see what's on the enrollment form and what services that were provided, then we are able to determine which funding source will pay for that visit. So RHEA only covers women who are able to become pregnant. Title 10 will cover men and women who are achieving or preventing a pregnancy. So from your side of it, you're just billing the RH program, and we will reimburse you out of the funding streams that we are determining from the information that we get from what you send in. Anything else? Then let's move on. So let's talk a little bit about what are the services that are covered under the RH program. And we're kind of putting this umbrella out for everybody to see as a coverage. So everyone gets preventive reproductive health services in the context of a family planning visit. That includes well woman annual visits, contraception, STI screening, and chlamydia gonorrhea treatment, preconception visits with infertility as well, pregnancy tests, and options counseling. Plus, because we do have RHEA, which is for individuals who can become pregnant and who do not qualify for Medicaid because of their immigration status, they are able to come in and get standalone STI screening and standalone well woman annual visits. But the RHEA does not cover any of the treatment if they have a STI screening outside of family planning, which is where our other funding streams will cover that. How are we determining this is by your codes. Before the only agent program that actually required a code was CCARE, and you had specifically had to use a Z30 code in order for it to be covered. We have expanded that ICD-10 codes so that we can determine what funding streams we're going to use. At this time, we're still using the number 1 code as primary code until we get into phase 2 with Ehlers. So right now, number 1 is the code we're going to be looking at. And so we want you to code correctly. We want you to put in the code what the primary visit was, what you did in that visit, and code it correctly. And then we on the back end will determine where the funding comes from. So we have a couple of visit scenarios just so that maybe it helps with questions that you may have or give a little bit more understanding of what we're talking about. So the first visit is Teresa. She's a U.S. citizen and she's coming in for a well woman visit. So the question you have is there a discussion of achieving or preventing pregnancy during this visit? If the answer is yes, then that visit will be covered through our RH program. If the answer is no, then there is no coverage through the RH program, and you should screen for eligibility for other programs that she may qualify for, like OHP. Second visit, Hemenia, she's DACA status or another immigration status. She too is coming in for a well woman visit. Again, the question is, where is a discussion of achieving or preventing pregnancy during the visit? The answer is yes or no. We will cover it through our RH program because it will be a RHEA coverage service. Visit 3 is John. He's a U.S. citizen. He has no symptoms, but he's requesting an STI screening. So the discussion of family planning, and this means is there much more than just talking about preventing of an STI with a condom. Are we actually speaking of family planning, a consideration of vasectomy? Are we talking about a partner's choice of method? Any of those kind of things that rises to the visit, you would code that with is yes if the family planning is a primary diagnosis, and we will cover that visit. If there is no discussion of family planning, he does not want to talk about it, then there is no coverage for the RH program, but you certainly could screen him for eligibility for other programs like OHP and actually the STD program. John now is an undocumented client. He comes in, he has no symptoms, same situation. Again, is there a discussion of family planning? And if the answer is yes, the family planning must be your primary diagnosis, and then we'll cover that. But if it's no, there is no coverage for our program, and you'll have to screen them for eligibility for other programs. Ella, she's a U.S. citizen. She's coming in for a contraceptive method start. She's symptomatic for a yeast infection, but she's needing her chlamydia and gonorrhea screen done. So what is covered through the program? We will cover the visit, the chlamydia and gonorrhea lab outside of the visit, the contraceptive supplies, but we do not have any treatment reimbursement for the yeast infection. If her CT and GC came back positive, We will then pay for the visit if she's needed to come in and have more discussion with her. We will pay for the treatment drugs for the chlamydia. And now we're also going to be paying for her EPT. And that is only in the case where the client will actually take it with her. We are not able to do that if your STD program calls up her contacts and gets them in. We're unable to pay for that. Then also we will then pay for the 3-month rescreen visit, and we will pay for the chlamydia and gonorrhea lab again. So Ella is another immigration status, same situation, contraceptive methods, yeast, and chlamydia screen. And what do we cover? We will again cover for the visit, the lab, supplies, but no coverage for the treatment of the yeast. If it's positive, we will cover the visit. We'll cover the treatment of drugs for the chlamydia and also the EPT. We will also do the 3-month rescreen. We'll cover the visit and the lab as well. Janet is a U.S. citizen or another immigration status. She's coming in for contraceptive method. She needs her gonorrhea chlamydia screen. She is greater than 250 FPL, or she declines to complete the RH program enrollment form, which she certainly has that right to do so. So what happens next? You need to provide all the appropriate services. You need to charge the client per the sliding fee scale, and you need to complete and submit a CVR. And this is true for all reproductive health visits, regardless of the payer source. Sheila is a U.S. citizen. She's an eligible immigration status or another immigration status. She's coming in basically for a diabetic check. She needs blood work. She needs to go through her case management. And then in the course of the visit, she says her implant needs to be removed. It's time. So what's billable to the RH program? Since the primary purpose of her visit is not related to the RH program or RH reproductive health, you do not bill the RH program. What happens if she comes in and she wants a depot shot? What is billable? The primary purpose of the visit is still not related to reproductive health, but you can bill us for the depot as a supply only. So we've had other webinars, and we will still continue providing the webinars this week and next week on the CVR, the billing and eligibility database, and the enrollment form. So any additional information regarding the RHEA covered services that we're not providing within your clinical setting, such as the screening mammograms, genetic testing, female sterilizations, we're still working on how that's going to all work. And so we will provide you information as we get that. We'll keep you definitely informed, and hopefully you will continue providing services as we have in the past. If you have any questions, you can ask them now. If not, we get off the webinar and you have more questions, feel free to call us, to email us, and get on the web and check out all the resources that we already have posted. They may help you with some of your questions. So, if anybody have any questions now? Okay, here's a question. How will we know if an encounter is going to have a family planning focus when I have not seen them yet? Usually clients will call and make an appointment for something. And so if they call and say, I'm coming in for, if you're a agency that also provides primary care, it's really important at the front desk to determine what the client is coming in for. So if they're making their appointment for a reproductive health visit, then you can pretty much think that it's going to be in that manner. And even if they come in a primary care setting FQHC, they go back to the reproductive health program, reproductive health services, and they complain of maybe a sore throat. If your provider feels that she is quite comfortable in treating that, that's certainly something that she can do, but it still is going to, that strep throat thing is not going to be covered under the RH program, and your codes would have to be coded correctly. What yours a primary visit and axillary if you did a strep culture, that's not going to be covered under our program. If you could send that over into the primary care side, then they could certainly address that and get a payment or sliding scale, or however the client has for services. So an example she had was a male who comes in for an STI. So people who, individuals who walk in the door with symptoms, and that's where we're talking about testing. It is not in the RH program that we're covering for testing. We will cover screenings. So if screenings happen to become positive within the context of a visit, for most of our funding streams, then that is covered. It's only those under RHEA, which now is a woman who's coming in and she has a screening, is positive, and we will then cover that treatment under a different funding stream. It's not going to be under RHEA. Question is, I thought CCare only covered one CT/GC test per calendar year, not two. Remember, we're braiding a bunch of funding streams together. So when a client comes in, no matter doesn't matter what the funding stream is, if it comes back positive, the RH program is paying for that out of a different funding stream. So it's how we're addressing it in the back end, it's how you're coding it in the front end that helps us determine where the funding stream is coming from. And I didn't understand that CT/GC was actually limited in CCare. You are limited to an annual exam in CCare to one every year. But if a client comes in for a refill of a birth control method and she hadn't had a screening done within her time frame, or if she's a high risk individual, there's other reasons to screen people for a chlamydia, then that is something that's always been available to do. Question. If we are CCare only, do we still need to fill out a CVR for any patient that comes in for RH? So, title. Oh, they're not a Title 10. So, as a CCare provider, you would not do that. You would not fill out a form. Question. If there is a patient coming in for STD screening but is not able to get pregnant, or someone pregnant, do they still qualify for the program? No. All of our funding is tied to the fact that they have to have the capacity of becoming pregnant or capable of having somebody become pregnant. That's just the limitation of what we have on our program for our funding. So the slides we've already posted the slides, have we not? Oh, so the slides will be posted on the web, and we will also have all these questions that have been asked. We will answer them and put that along with the slides so that you'll have both of them together. Another question came in saying, if someone does not qualify for the program due to income or does not want to fill out the RH application, do we have to offer a sliding scale fee, or can we have set prices for billing? As a Title 10 agent, you're getting Title 10 funds, you have to see all your clients on a sliding fee. So if they are over $250, they are, according to Title 10, they are charged full fee. Certainly, if you want to do a different arrangement with them, that is certainly your agency's option. But as far as our program is concerned, if they're over 250, the client should be charged the full fee. If they're under 250 and they choose not to do the enrollment form, then you have to put them on the sliding fee scale, and they're only responsible for wherever they land on that fee scale. Okay, a few more seconds here if anybody has any more questions. What's the next webinar?
Tomorrow morning is CPR.
All right, so we don't have any more questions. There is another webinar tomorrow morning on the CVR. And so if you want to make sure you registered, then you can get the slides and the questions afterwards as well. And we also have, we still maintain our Wednesday 9 to 10 office hours for people that want to call in and ask us any question, or if you want to share anything with us. We're happy to talk to anybody that wants to call us. Wednesday from 9 to 10. All right, well, thank you for attending. We will send out the information as soon as we get it done. Okay, another question. Will that cover abortion? I'm not quite sure what you're asking, Anna, but you know, the REA Act did include coverage of abortion. We have contracted with Planned Parenthood of Columbia-Willamette and Planned Parenthood of Southern Oregon, as well as Lovejoy, to provide that service. And it's only for the REA population. They would need to go to those organizations and fill out the form. I hope that was answering your question, Anna. Okay, thanks. All right. Thank you guys for taking time out to attend. And if you have any questions, be sure to let us know. We're all here to answer any of your questions. Thank you, Lisa. Bye, guys.